Hey, everyone. Welcome back to the Vocal Pelvic Floor. If you've ever dealt with chronic pain, joint instability, or hypermobility, and you have endometriosis or think you might, this is your episode. Today, I'm talking with Dr. Libby Hinsley, physical therapist, yoga therapist, and strength training expert who specializes in hypermobility syndromes. We are going to dive into the connection between hypermobility and pelvic health and overarching musculoskeletal health, and the medical gaslighting so many bendy people face, and how to build strength and stability without pain. Libby shares her personal journey with Ehlers-Danlos Syndrome and why understanding your body is the key to reclaiming your health. Let's dive in. Hello, everyone, and welcome back. I am here with an amazing guest because she specializes in something that is I'm intensely, ridiculously, passionately interested in. And it's anything to do with hypermobility. So if you have hypermobility, all right, stay with me, listen to the entire thing. This is Dr. Libby Hinsley. First of all, Libby, welcome.
Thank you so much for having me.
I am so glad you're here. All right, you guys, for the bio, I need to do a little bragging. So Dr. Libby Hinsley is of course, a doctor of physical therapy. She is also a yoga therapist, a personal trainer. She specializes Anyway, she specializes in the treatment of hypermobility syndromes, which naturally you would think goes along with persistent pain. She has a book, Yoga for Bendy People. Obviously, yoga about hypermobility and tackling that. It came out in 2022 and explores how people with joint hypermobility syndromes can use yoga as a tool to support their thriving. She's developed a successful strength training program for people with hypermobility syndromes, and as a person living with Ehlers-Danlos syndrome, hypermobile EDS, and related health conditions, she is passionate and committed to raising awareness about hypermobility syndromes in the yoga and PT communities and beyond. And she also teaches in yoga teacher training programs called Anatomy Bites. I think that is so. Where did that name come from? That's great. And before we are all done, I'll tell you about where you can find Libby. But tell me about Anatomy Bites.
Yeah, well, Anatomy Bites was kind of born out of COVID, actually, when I had to shut down my in-person stuff. And I had this idea percolating for a long time. And I'd been teaching anatomy to yoga teachers. And I wanted to make a program that made anatomy fun, like specifically for people who think anatomy bites, like anatomy sucks.
Yeah.
But also it's a play on words because it's basically delivered in little bite-sized chunks frequently so that people can learn and process it and not be overwhelmed like so many often are when they're trying to learn anatomy.
Yeah, that's so neat.
Yeah.
I have such a passion for this topic. I don't think I've ever really mentioned it to anybody because it was subtext in my own head, but hypermobility and yoga was the reason that I wrote my first book on yoga, medical therapeutic yoga, because of the kind of the use and abuse of yoga just for mobility and flexibility and my favorite awful word that I hate to hear, flexibility.
Yeah.
That it's all about flexibility and about nothing else. So I love that you are tackling this topic. You've done a lot of work in educating clinicians about hypermobility syndromes. How did you first really recognize the link between hypermobility and just pelvic health challenges?
Well, I didn't know I had EDS until about 4 years ago, 5 years ago now. But I was plagued by all of the standard signs and symptoms for my whole entire life. I've had pelvic organ prolapse since before I had kids, and I was just always like the outlier, but also functioning pretty well. So, there's lots of medical gaslighting. That's the general experience of the bendy person, I would
Oh,
say.
yeah.
And you end up just gaslighting yourself because you're so used to being gaslit. So anyway, I'm still trying to come out of that, but basically I did do pelvic PT for a while, some years back around my zone of having kids. I got really into that. And but treating, pelvic health patients, and also just treating yoga practitioners and yoga teachers with all their aches and pains over the years, I just noticed I was seeing a ton of bendy people, a ton of people with hypermobility. They turned out to be just like me. And I was like, gosh, I have kind of the same issues. I always have had the same issues. So it was through my own experience, but also kind of reflected in my clinical practice, that I just became more and more interested in hypermobility as the thing that was tying together all these different challenges across so many systems of the body, right? Because these are the people who had maybe some incontinence, some prolapse, some pelvic pain, but they also had wide ranging joint pain, myofascial pain, headaches, TMJ, fatigue. There, more propensity for autoimmunity, POTS, dizziness, all the things, then, and they were the people who were like so chronically healthy, like doing all the right things to keep themselves healthy, eating a super clean diet, right? And being really mindful about taking care of themselves. And yet, despite all that, they were having all this chronic pain. And that was the same as me.
Yeah. So you rattled off a list because you're you and you do this stuff all the time. So for the listener, can you go back through that list of things that women may expect to feel or could feel? Because there is a spectrum, like so many things are a spectrum, right? And I think this is one of those things, but like start at the top and kind of go to the bottom of all the things that they could feel that they could potentially get gaslit about that could in fact be hypermobility.
Yeah. So you're right. It's a spectrum situation, but I like to think of it as a spectrum of variety as much as it is a spectrum of severity. And so many people are like, oh yeah, I've got like a few things, but it's not as bad as fill in the blank. And that's what I would have always said. It's not as bad as somebody who's like dislocating their joints all the time, but that's not always what it looks like. I've never dislocated a joint, and I have EDS. So, so yes, I'll kind of cover all the different places where hypermobility syndromes can show up in the body, in this like musculoskeletal realm. It's common to have wide-ranging joint pain, almost like inflammation kind of feeling, sort of systemic, or a propensity to have tendinitises a lot, and it's moving around. I like to call it the game of whack-a-mole. And the thing pop, and you whack it down, and then the next month it's over here, it's the elbow, but oh, now it's the knee, and you sort of spend time chasing all these usually minor aches and pains. Maybe there's joint instability, maybe you do dislocate, or maybe there's just a sense of extra wobble. There's like a partial subluxation, a partial dislocation. So all those joint problems could be a sign. I will say the top 2 or 3 joints that are problematic are the SI joint, the TMJ, and the shoulder. Those be okay. And then this is a person who's very prone to develop myofascial pain. So their muscles hurt, muscular tenderness. There's a high overlap between a fibromyalgia diagnosis and hypermobility. This certainly could coexist. Maybe they're misdiagnosis, who knows? But that experience of being very tender to the tissues is really common. Also, fatigue is super common. And it's the kind of fatigue that's just not normal fatigue. It's like not alleviated by sleep. Sometimes along with the fatigue is exercise intolerance. Someone classically goes to their exercise class, works out at the gym, they feel fine while they're doing it, or maybe it's a yoga class or Pilates class, whatever it is. The next day, they're laid out with fatigue. They're exhausted for a day or 2 or 3. They have stronger muscle soreness response. So we know bendy people tend to have a stronger delayed onset muscle soreness. So it might look like that. They often have pelvic health concerns, whether it's pelvic organ prolapse. I'd say that might be the top of the list because that's even one of the diagnostic criteria for HEDS, hypermobile EDS. Incontinence, pelvic pain, all manner of pelvic pain syndromes. Let's see, other common things, dysautonomia, which is a fancy way to say that the autonomic nervous system has a hard time regulating heart rate and blood pressure. That can look a lot of ways. The most common way is POTS, postural orthostatic tachycardia. So people get dizzy, lightheaded, brain foggy. They might have stomach pain. In addition to that, they often have GI issues like IBS type things, maybe delayed gastric emptying. They might, it could look a lot of different ways. The list is really long, actually. So I'll add a couple other things that are super common. One of them being neurodivergent diagnoses. So like we know people with ADHD and autism spectrum disorder are 4 to 7 times more likely to be hypermobile and vice versa. So there's a lot of overlapping kind of Venn diagrams, we could draw.
Yeah. That was a really great overview. And so, okay, if you're listening and Libby just outlined like 15 things that you feel, know that you're in the right place. Keep listening. Okay. We're going to keep talking about this. There is help. This is not something that you're just going to get eternally gaslit for and about. There are definitely concrete things that can be done. And that's what we're going to be talking about. Our focus today on hypermobility is really circling around the endometriosis camp. It is probably one of the top misunderstood and misdiagnosed conditions out there. And so what I just want to open the conversation up with is, how does hypermobility complicate or intersect with endo symptoms?
It's a really good question. And there's not really a ton that's understood about it yet, but it appears to be a thing, right? And where to begin?
Wherever you get the most fired up, that's where you should begin.
Well, I would say, someone with a hypermobility syndrome and someone with endometriosis might be the same person. And a lot of times they're not the same person, but there's certainly going to be some overlap. And it, even though the research isn't really suggesting a stronger than normal overlap yet, anecdotally, I just keep hearing in the last few years more and more and more about this. People are starting to wonder, is there actually a link between hypermobility syndromes, a connective tissue disorder, and endometriosis? And if there is like a pathophysiological link, like a causal link that connects these, it's probably in the mast cell department, is what I'm gathering from research that's sort of implicating a role of mast cells in endometriosis. And we know that bendy people very commonly have problems with their mast cell activation syndrome, where they have histamine, a lot of histamine and other inflammatory things going on, itchy, rashy, inflammation. But what I get most fired up about is the medical gaslighting that both of these people would have experienced for probably many, many years. So
they get a double whammy.
A double whammy, absolutely. And let's say they have both. I'd say the endo is going to just be like a magnifying glass to all of their other challenges, and it will just amplify them. It's going to amplify their sensitivity to pain. It's going to, further sensitize that nervous system that in the bendy person we already know is poised for hypervigilance. The bendy brain is different. It's got a bigger amygdala. It's got a more reactive amygdala. Did it come in that way, or is that an adaptive response to bendiness? Who knows? That's an interesting question. But either way, it poises us for chronic pain and for that sensitivity that is associated with chronic pain. So the endo is kind of doing the same thing, and it's going to just amplify all that. Lead to fatigue, and already with the mast storm. It's a perfect storm. Yeah. And so it's like a tangled ball of yarn. I mean, I see hypermobility syndromes as a tangled ball of yarn, and endometriosis also seems to be that. Both of them are not well understood. In both cases, it's very hard to find a medical provider who knows much of anything about it. And yet they're not rare conditions. We know endometriosis, it's not rare. Oh my gosh.
You just hit the nail on the head. If you're listening, you haven't heard much about endometriosis, but you have some of these signs and symptoms. Think about it this way in terms of statistics. 1 out of every 10 men have diabetes. Everyone knows what diabetes is, right?
Mm-hmm.
And there's about 15 times more funding for diabetes than endometriosis per person in the United States every year. 15 times more. And yet the same number, and probably more women, suffer from just endometriosis. You could probably share some stats on, the hypermobility side of things. That's a lot of women. And you're exactly right, Libby. This is common. It is not uncommon. And yet we don't have enough funding to even create enough literacy inside our own healthcare system to stop gaslighting people.
Yep.
Mostly women.
Right. I mean, it's shocking how common it is. And I think if we knew the prevalence, had a better idea, prevalence of hypermobility spectrum disorder and hypermobile Ehlers-Danlos syndrome, which we'll usually just lump together as the most common forms of hypermobility syndrome, and they present identically in the clinical sense. They're diagnosed a little differently right now. But anyway, if we were to know the prevalence of that, many suggest it's probably similar to endometriosis prevalence. Now, the best research we have is based on diagnosed prevalence of hypermobility spectrum disorder and HEDS in a population in Wales, not swimming whales, but the country whales. Swimming whales might also be bendy. I don't know, but this is about the country whales. And that research shows that 1 in 500 people had one of these conditions. Okay. That's diagnosed. We know the diagnosis rate of these things is unbelievably low. Many place it around 5%, meaning 95% of people who have them are not diagnosed.
I believe that.
So the prevalence of these conditions is likely mind-blowing. I think it's probably in the single digits would be my guess. But of course, this is all I think about. So I'm gonna aim high, and I see it all the time too, because it's kind of my world. But regardless, it's much higher than it's been appreciated in the past.
Yeah.
Mm-hmm.
So given the rates of underdiagnosis for endometriosis and underdiagnosis for hypermobility and the syndromes associated with hypermobility, what are the most common patterns you see in patients who have both hypermobility syndromes and pelvic pain conditions like endometriosis would cause?
Like clinical presentations?
Yeah, exactly.
Yeah.
They would come in and sit down, and what would they say?
Well, they just have chronic things, and they might downplay them. So I find that these populations are underreporters. Okay. So you might have experience with overreporters, and usually those aren't women in general. These are underreporting. All right. So so hard to describe this, and it's hard to get a sense of that maybe as you develop some rapport. But there are people who have normalized their own symptoms for so long that they act like they're no big deal, even though they are life limiting, their quality of life limiting, and that's very obvious. So things like, how are they managing their fatigue, their activity tolerance being low, their pain, being pretty widespread usually. Certainly if there's coming with pelvic complaints, then we're going to see, the incontinence and the prolapse symptoms, pelvic pain, pain with penetration, pain with exam, painful periods, heavy bleeding, problems, all of those things, propensity for excessive bleeding during childbirth, things like that. Neck and shoulder tension, common. It's like they're going to appear like complicated patients is basically what's going to happen. And they often also at the same time are quite high functioning. So there's a little bit for a lot of practitioners, it doesn't make sense, right? They're seeing a person who's very high functioning, achieving a lot, managing pretty well, and who's got all this long list of complaints that sort of doesn't match their high functioning status. And I think that's what leads to so much gaslighting, right? True. I mean, I've experienced it with my EDS stuff. I went to so many specialists. They all did the same thing to me that they do to everybody else. There's almost no chance there's anything wrong with you. You're way too healthy to have all these problems. It's like they literally just don't believe you.
Don't believe
You
you.
know,
They don't
they just
believe
don't.
you.
So then you're like, oh, I guess I'm okay. I guess this is what it's like to be a human being in a body. I'll just carry on with my struggle and assume this is kind of normal, right? But then when something becomes once again unmanageable, or they renew their inspiration to finally try something different and resolve it again, it's really in spurts, right? They go in spurts of seeking medical care.
Yeah.
And maybe they're a few years apart. The last spurt didn't get me anywhere, and I managed for a few more years, and now I'm in another spurt and I'm coming to see you. That's kind of going to be the story, right? But you got to know that these people are underreporting. They have been dealing with chronic pain and chronic things that are taking up so much of their time and energy to manage for years and years and years. And it's not normal, actually, to live that way.
Well, it is. When we talk about the trauma of medical gaslighting, that's a whole like sphere and universe in itself where, that requires seeking out help for that.
Yeah.
That's the mental damage, right?
Mm-hmm.
That gets done when you have been gaslit and not believed. And then you start to gaslight yourself.
Mm-hmm.
Of course, then that's a whole therapy thing that you have to go through. And then you're still hurting. No one has addressed it. Now you have these mental health issues that are valid because of the gaslighting, but you still haven't had any of your physical symptoms taken care of.
Right.
And I would think that this underreporting of the trauma and self-managing and keeping things kind of a secret would spread over into other areas of their lives too, right?
Mm-hmm.
Does that
Yep.
put them at higher risk? And this is not a question that we can answer today. It's just a question for the ether. The question for the ether is, does that put these people who have, it's almost like if someone had experienced adverse childhood, trauma. So adverse childhood experiences, or what we all know in healthcare as ACEs. People who experience ACEs go on to tolerate other levels of abusive behavior from other people, and they normalize it, right? They normalize the abnormal because that's all they knew growing up. So it makes you question, like, how much are they putting up with across their whole life? Are they in toxic work relationships? Are they in toxic personal relationships? Are they putting up with pain? Where the average person who didn't have all the pain they went through, are they putting up with things that at some point we break the cycle and go, hey, you can push back on that, right?
Yeah.
You can say, you can call, and we can swear here. So we can say, absolute, all right, that's bullshit. Because at some point, if we can intervene and teach them how to not put up with that anymore, it's liberating on multiple levels.
It is. And I see it all the time. Again, it's not a question we can answer, or like have data on, most likely, but my guess would be definitely this is a population who, at least due to their experience of gaslighting, that is a trauma experience. They have been taught by their experience to distrust their own bodies and what they're communicating to them, their own sense of how to make decisions. They have very often gone to 20 different doctors trying to find the person to hand over their power to,
Gosh, yes.
who's the right person to fix this. But no one has been able to take it on in a way that's empowering and actually gives the power back to the patient to learn about their own condition. So I think it's detrimental in every part of life. And I do see it all the time with my clients and patients and in my own life. And I'm now, as a mom, I'm just this week had to catch myself trying to medically gaslight my own kid, I'm like, it's really not a big deal. Is this a big deal? And I was like, oh my God, of course we should explore this. You know what I mean? But I'm so used to downplaying things that I have to catch it.
I think that's worth pausing for. So, message to everyone listening would be to trust yourself.
Yep.
Believe your own experiences. Because if you have any of these symptoms at all, you may have never even considered hypermobility or endometriosis as part of your journey or a possibility. But if you have some of these symptoms, believe them. Don't dismiss them. Trust yourself, believe in yourself. And if you have to doctor shop, don't should yourself to death. Should I do this? Should I do that? Should I even bother them? Just keep doing it. It is not a negative or a bad thing to have to doctor shop until someone listens, particularly with these conditions, because they overwhelmingly impact women. And we are like neck deep in papers that show how badly women are medically gaslit.
Yeah,
especially when it comes to their anatomy.
So yes, and keep looking, and don't stop looking until you find someone who validates your experience. And I would say it is worth pausing on. It's the thing that is like the missing step in between suffering and like recovering or learning how to deal with these things is learning to trust your own experience and having people on your healthcare team and in your life who empower you to take back your power and to say your vessel, like your body isn't broken. It's giving you the information. It has been giving you the information this whole time. It is brilliant at giving you information. So you can actually trust it. And so we have to learn, what's it feel like when something doesn't feel right? What's it feel like in the exam room at the doctor? What's it feel like in my relationship? What's it feel like at work? What are the signals that my body is already giving me? I have to learn how to recognize them and do not ignore them anymore.
Yes, let's fist pump for those of you not watching on YouTube. Yeah, I mean, amen to that. First of all, I want to thank you for listening. We've had so many downloads and so much incredible feedback. So thank you. And now I have an ask. If you could, and you found this work valuable in the endometriosis and pelvic pain space, in the ending medical gaslighting for women's and pelvic health space, if you could do one of two things, I would be so grateful. One is to leave us a 5-star review. The link is in the show notes, or you can just simply open up your app. And for example, if it's Apple, just go to the upper right-hand corner and click the plus sign to subscribe. 2, if your finances allow for it, could you please consider making a contribution? We don't receive any funding and haven't the entire time to create this podcast. So all of the production costs are coming out of my pocket. We aren't making anything on this at all. It's costing. So every bit of support that you can lend will make a massive difference. Thank you in advance for being a part of this work. Whether or not you've been a guest on the podcast or a listener, or you've downloaded episodes or subscribed and shared, I appreciate it. So if you could leave a 5-star review and consider making a contribution, it would really help the work continue. Thank you. So to circle back to a couple of things that I want to glean a couple of points here, and that is little girls probably won't leave their adolescence without having some kind of sign or symptom of either hypermobility or endometriosis or both. Unfortunately, that may be your first ACE, your first adverse childhood experience, which is horrible because of the under-recognized, under-researched, under-attended to nature of these issues. It could mean that you experienced institutional betrayal in a place where you should have been accepted, like open arms, safety, sanctuary, everything that healthcare should be. You go to people as subject matter experts to take care of you, save your life, and improve your quality of life, and you got the opposite. It's totally unfair. So that hypervigilance of the nervous system may not lead you to be quote, quote, hypersensitive, which is that's part of the gaslighting, right?
Mm-hmm.
Oh, you're just hypersensitive. Oh, you just notice too much.
Mm-hmm.
Oh, you just fill in the blank.
Mm-hmm.
Much like someone could gaslight you if like they were, a narcissist trying to just play down your entire experience of your whole life.
Yeah.
And with that destabilization of the nervous system, as a therapist and across the therapist collective, right? Mental health, occupational therapy,
Mm-hmm.
pelvic health, pelvic PT, pelvic OT, et cetera. There's a lot of therapy, right? That kind of, we need a team. It takes a village.
Yeah.
When you're working with that experience, chronic pain, fatigue, nervous system dysregulation, how are some of the ways that you approach stabilizing the nervous system in patients who might have both endo and hypermobility?
Mm-hmm.
And obviously they've been medically gaslit. If you have these issues, no one is going to probably listen to you the first time you go in and sit down and talk about your symptoms. So how do you help them kind of come back to that kind of heart center calming place where they can self-regulate?
Well, that's going to be the journey. And you're so right. Oh my gosh, I see so many teenage girls who have been diagnosed with just anxiety
Oh
or,
gosh. Yes.
and or disordered eating.
Oh,
And
yes.
what's happening is that they are starting to express symptoms of EDS and POTS, and they're dizzy, and they are interoceptively sensitive. We know that about people with hypermobility. So they do feel more inside their body than typicals do. That's not pathological. It's a unique physiology that they have. They haven't been educated. They've just been said, oh, you're too sensitive. You're feeling too much.
Right.
Well, they actually are extra sensitive. That's their superpower, but it just gets twisted around and, described in a negative way.
Right. Ooh, let's hit that ball out of the park, because that's a really important point, is that you do have that special interoception. Interoception is knowing how you feel. And so in mental health therapy and physical therapy, for example, we are going to ask you constantly, like, how do you feel? How does your body feel with that? And so, Libby, you just said it like, oh, that's so perfect. Okay, 2 fist pumps now. Okay. 2 fist pumps, not just one. That special interoception that you have is your superpower. Don't let anyone pathologize that and tell you it's wrong. Exactly. That's what keeps you safe. It is your body's superpower that is protecting and self-preserving.
Exactly. Yes. So changing the narrative for them is the primary thing, and that rapport, that therapeutic rapport that you hopefully develop with your clients and patients, that helps them to feel safe, that you believe them, and that we're going to learn from the body. So this has to be the kind of paradigm, that you present to the person you're working with, is like, we're a team. I'm on your team. Your body is the expert, and we got to learn its language. We have to, get to know it over time. This is going to be a process, but we're going to try some things and then study your body's response really closely and document it, and then adjust accordingly, and then try this. So they have to know from the outset that we're in a process. I don't have all the answers. They actually have all the answers, and I'm going to help them decipher the information, because the body is particularly sensitive, the nervous system particularly sensitive in this crowd of people. And again, that is an asset. But because of that sensitivity, the signals can be so overwhelming and difficult to interpret, and understand, what do we do about it? That's the task, is to try to learn about that through practicing, sensory awareness, really basic things. Less is more is one of my mottos, especially when we're doing like exercise. I find resistance to be such a great tool to improve sensory awareness, rather than just pumping iron just for the sake of it. It's like a sensory medicine almost, every single little repetition. That resistance helps people feel, and they're like, oh, I did feel that muscle. Wow, that felt really good. Because we know that the bendy person and the person with chronic pain, right, just across the board, they have blurry body maps in their brains. maps of the body. Their brain's like, it's a murky picture. It's not a clear picture of the body. And that makes it difficult to really differentiate what's going on in the body and understand these sensations. So through practice, through paying attention to how we feel, those little maps up in the brain get clarified and have an easier time connecting with our body parts.
Yeah, it's like a camera from out of focus. Before we had iPhones, right? When you'd take an out of focus picture from your third grade field trip versus one that's, has high clarity and like high fidelity sound to it.
Exactly. Yeah.
So one of the things I was going to give the audience is kind of an example, and you can like refine it or give me another example or that kind of thing. But I was just working with someone who you pretty much described perfectly this morning, actually, in patient care. Because this is how it rolls around here, y'all. It's podcast in the afternoon and it's patient care in the morning. So she was in that ACE experience, right? And an adverse childhood experience. Younger, hypermobile, endo, like all the things. And I thought it was absolutely brilliant that she hit on the interoception and proprioception that we're talking about right now. So for those of you listening, you're like, what the heck? Okay, interoception, which we touched on earlier, is the ability to understand how we're feeling internally. Proprioception is what Libby just talked about, is where am I in space, and that body map, right?
Yeah.
And she so brilliantly described that this morning, because that is, I feel like that's one of my chief jobs, and I'm sure you probably feel the same. I think it's really, really interesting that the trauma literature, especially from yoga work and the work of Bessel van der Kolk and others who wrote The Body Keeps the Score, talked about how introducing movement instead of just talk therapy helped people lose their complex PTSD diagnoses. Yeah. And the key to that was focusing on interoception and proprioception as a means for regulating the nervous system. So teaching them where they are in space, teaching them to understand how they feel, that actually helped their mental health, not just their chronic pain, which was brilliant. And so this young girl this morning looks at me and said, basically, that's my goal. I want to be able to differentiate how I'm feeling and understand it, which sounds so minor, but when you know the science behind it, it just is kind of mind-blowing that already at such a young age, she's experienced so much institutional betrayal that she can already recognize she wants to be able to trust herself and her body and where she is in space and regulate that. And so I think an example would be, and I'll just pull one out of the air from like one of the many points we were hitting on, was like being able to differentiate between what might be ovary pain, right? Like a period type pain versus a psoas or hip flexor type pain, right? If you could understand the difference between those two types of pain, and there are ways to differentiate it, which I think is part of our job as therapists, is to help them understand that, gosh, that tamps down fear, right?
Yes. And
it changes the treatment, because we may do something different for ovarian pain versus what we may do for psoas, type hip flexor. Snarky psoas is what I call it. But I'm sure you have other examples where you can kind of expand on that from patient care of how important it is to be able to distinguish it. It puts you in the driver's seat. Like you get your power back as soon as you can differentiate those things.
It's so true. And just ask people to lean in, to kind of zoom into their sensory experience. They might say this hurts or I have pain here, but to lean into it and say, I want to know more about that specifically. How specific can you get in your description of that sensation? Because now they're like, oh, now I'm kind of curious about the sensation rather than just being scared and wanting to avoid it because it is pain or whatever, the big umbrella category they might be putting it in. So the minute they're like, oh, how would I describe it? Gosh, is it sharp? Is it dull? Does it travel? Now we're in the mode of curiosity. And that's, I think, their best friend. If they can get into curiosity mode as they study their experience, boom, we are on our way. Because it's hard to be afraid of something you're curious about. And fear of our own bodies is like, it's the worst. It's the biggest barrier, fear of movement, fear of discomfort. And we're so afraid of things that we can't understand yet. Mm-hmm. So, it's valid that people are scared. It makes sense that people are fearful of that. But to start unraveling that with curiosity, I find really, really helpful. Another thing would be studying joint pain versus muscle soreness after exercise.
Yeah.
Learning the difference there. Like, is there a sharp shoulder pain, or do I feel like, I did some rowing exercises and now I'm aware of my, interscapular muscles. They're a little bit fatigued and sore, and that's normal, those types of differentiations are really, really helpful.
Yeah.
I just came out of teaching Bendy and Badass, which is the strength training class. We had 2 classes today, both of them full of bendy people, like 10 people each class. It was so great. And they're learning, how to do some strength training moves, but we're really using the resistance, the load, as a sensory training tool. How can this exercise, any modality of exercise or movement or manual therapy, really, any kind of treatment approach, how can it train my nervous system to understand my body better? That's really the task. Yes, we're kind of going for strengthening too, but what's so much more important in the chronic pain realm and the bendiness realm in what we're talking about is that better ability to sense embodiment, to arrive inside your body versus having an out-of-body experience, which is often what we're having because we have gone to that sort of dissociative place because of our trauma response, fear, discomfort, all those things kind of drive us to
and cultural conditioning as well.
Yeah.
People all the time are like, look at how strong she is. She didn't even cry. Look at how strong he is, especially for men too. He didn't even flinch. I'm like, since when is strength being absolutely stoic and pushing everything under a rug so that you don't even know what you feel, right? So I think there's a lot of cultural conditioning that goes into it as well.
Yeah. And one thing I'll hear all the time from the hypermobile person is they will have gotten into a habit of describing their body parts as being out. So my shoulder is out, my sacrum is out, my hip is out, my rib is out, everything's out. And so, sometimes I try to make light of things a little bit, keep things lighthearted. And I'll ask, where did it go? Where did it go out? We got to find it. We got to bring it back. But also, understanding that is like something doesn't feel quite right. And so I want more information. Yes. So I'm always asking for just more detail. I'm curious about that. Tell me more about, where do you feel that? What's it feel like, And then eventually I might talk about how stable the sacrum is and that it doesn't travel far. It might travel a little bit extra, but maybe a few degrees, But that there's certainly pain there. There's discomfort there, and we might have a better way of describing it and understanding it that isn't so scary, actually.
Yeah, I think that may be one of the chief things that is incredibly important about physical therapy in these populations is that we can teach them not to be afraid of movement. Now, we call that kinesiophobia. So if all y'all that want to nerd out, all right, we're kind of unraveling that kinesiophobia so that you're not fearful of movement anymore. Because you then can discern, oh, well, that felt like fascia, or that felt like muscle. That was more mechanical. That might be a joint, right? Discerning that, and I often will give patients a decision tree in their homework. Like, if this hurts, I want you to try this thing, and this thing. Okay. If it's A, then it's like choose your adventure.
Totally.
Choose your adventure books.
Yeah.
Or if it's A, then I want you to choose number 1. But if it's B, you got to go with number 2.
Yeah.
And so it puts them in the driver's seat of, I do think that this is a mechanical issue. I need to schedule a therapy session, or you know what? number 2, that worked well. I'm going to stick with that and self-manage at home.
Mm-hmm. Yeah, I agree. I use a lot of self-massage, soft tissue treatment modalities. I happen to like therapy balls. There's all kinds of tools. So one of the things I like to do is encourage people, say they're doing a set of squats and their little patellofemoral pain flares up at rep number 3. You don't need to keep going to 8 or 10. Stop at number 3. Get on the balls. Deal with your quadriceps. It's yanking on that patella. Then get back to it and finish your set.
Yeah.
You don't need to just keep going when this little tweak comes up. We're going to address it right now and then get back to it. And they're like, oh my gosh, it does feel better. You know?
That you just gave them permission to kind of self-prescribe, which is good because we have this all or nothing society, right?
Mm-hmm.
Where if you're working part-time, you're not really an expert at that. Or if you can't do the full 30-minute workout, then you might as well not do it at all.
Mm-hmm.
Like, we know those things aren't true, right?
Yeah.
You can have subject matter expertise at any level, and you can enjoy fitness even if you broke up 30 minutes of exercise into 2-minute segments across an entire day. You're still going to be just as fit, maybe even more fit, because you probably worked harder in those 2-minute segments than you did the full 30. But that is such a hard mental thing to break for people, that they can take a break and then come back to it.
It's almost impossible, it seems, to learn that. It's so hard to overcome. I feel like a broken record. I'm always saying there's nothing magical about 10 reps. Oh my gosh, do 3. 3 is amazing because I want quality,
Mm-hmm.
and the 3 slow, reps using the correct target muscles are so much better than 10 mindless reps where your knee's hurting or whatever it is. It's not even worth it really from that sensory retraining standpoint and stuff. So it's such a hard habit to overcome.
It is. And it doesn't seem like we ever fully beat it. Full transparency. I'll give you an example. Before kids, I could do my hour, 90 minutes worth of yoga, all strength based, working on holding it all together. And then I had kids. And then I could only do 5 minutes here, 10 minutes there, 30 minutes here, 10 minutes. And it took me being forced to take those breaks, to learn that I could be in better shape than I was before with less injuries.
Yeah.
Right? I mean, that I didn't have a choice.
Mm-hmm.
And do you think that I learned my lesson?
Mm-mm.
No, I didn't. I will still do that to myself. If I have, after we're done with this podcast, I'll have a little bit of time before it gets dark, right? Am I going to do the 10-minute dog walk, or am I going to go, I wish I could actually go run the 3 miles. I'm just not going to take the 10-minute dog walk. What? I didn't learn anything, right?
Mm-hmm.
So I just want all y'all to just realize that although you might learn the lesson once, you're going to have to learn it for every season and every phase of life that you're in. Yeah. We'll still have these struggles,
Yeah.
But interval training can really, really get great results.
It's true. I mean, this is why I still have a coach, and she tells me what to do 5 days a week, and I do my assignments. And if I didn't, I either wouldn't do it or I'd do too much. It just wouldn't be. It would go sideways. I just know it would.
That's smart. You know what strategies you need, and I think that's that hits the point. That's the home run. That's what we're talking about. Yeah. Is if you know how you learn and how you move and how you feel and what conditions you work best under, set that up for yourself, right? Mm-hmm. And don't worry about how everyone else gets to exercise or move or how their sleep looks like, or just don't even care. And I think that's a blessing of, I think for me, reaching 50, right? Mm-hmm. There's all these other changes that happen. And that's the next question. Gosh, so we're talking about younger women and their struggle, and then motherhood and that struggle with hypermobility and endo. What happens when women hit 50 and beyond? And I think for me, learning those boundaries and setting those limits, just in time management and the whole, you don't have to do all or nothing, right?
Right.
is a shift because your bullshit meter, your BS meter, your radar or whatever, you're just like finely tuned and you know how your body works and what you want to do with it. But anyway, that just is just full transparency for me. But that's the next question. How do you see women present as they enter into perimenopause? I mean, postpartum can look like perimenopause for some time hormonally, right?
Yeah.
So how do you see women present differently, and really from a mental health perspective too, because that's a whole other special area of gaslighting, is a perimenopausal to menopausal to postmenopausal woman being told, oh, you can't have endo. You've already been through menopause, right? We'll just bust that myth and get that out of the way, like right off the top. But what do you see with hypermobility?
Well, I see that if things haven't caught people's eye in puberty and in perinatal time, if they had children or birthed children, then it shows up in menopause. That's when it comes up. And so plenty of people, especially women, certainly in the perimenopause, menopausal time, that is when they realize that they have a hypermobility syndrome. And that looking back on their life now, everything gets revised. And oh my goodness, this is why, my whole life makes sense. It wasn't enough to catch my attention maybe, or maybe I did pursue a little bit here and there 20 years ago. I never got anywhere because I just got medically gaslit or whatever.
Yeah.
And I managed, and now things really start to fall apart. And it's fatigue, and it's chronic tendinitises that travel all over the body, and tendinopathies, and bone density concerns, right? That's not going to be like they might have a fracture, but it's more, oh my gosh, I have my DEXA scan and holy smokes,
Well, one of the things I would love to bring up to people, thank you for mentioning that, is the current recommendations for DEXA scans is 65 years old.
Wow. Yeah. I didn't even know that. I wonder.
Yeah, 65. So if you're listening and you think that this is an issue for you and you've ever been on birth control or any other hormone suppression or anything like that, and even if you have not, please advocate for yourself to get a DEXA as soon as you can, particularly when you start experiencing perimenopause, because that's where you can lose the most bone density the fastest, is in that first 5 years. So even that, like, our healthcare system isn't even protecting women's bones, because at 65, can you imagine what damage is already done by the time they're 65 years old?
It's already done. And so I guess I didn't realize that was the recommendation was so late. I was hoping it was more like 55. I'm 48, and I knew I was too early to, have my doctor reasonably want to order one. But they're actually, the university in town, I recently learned, you can go pay out of pocket for a DEXA scan at their wellness department at UNC Asheville. And I did that just like 2 weeks ago.
Awesome.
Yes. And I was hoping I'd have a really good, solid baseline to follow over time. And I do, but it's not quite as good as I expected.
I know.
It's like, oh my gosh, I have been, in my mind, pretty hardcore strength training for years, especially several years, very consistently and heavy. And my muscle mass is low, not quite sarcopenia, okay, but low. And my bone density is low for my age. Now I have to get the more specific, site-specific testing to really get a value of that and see. But I was discouraged about that, actually, and sad. And then I realized, oh my goodness, can you imagine if I'd had a DEXA scan 3 years ago?
Right.
It's probably so much better now, actually. I bet I've improved, and I bet I was at such a significant deficit coming out of my childbearing years, and that's when my health totally collapsed, and I was very ill for a few years. And I was so depleted, I was like disintegrating, So I bet, and I've had a slow climb out of it ever since. So my guess is I'll get another one in 6 to 12 months, and maybe it will show some improvement, because that's my biggest concern. And with someone with a collagen disorder, a connective tissue disorder, the research does suggest we're at more risk for developing osteoporosis.
That's another area that's very much needed for robust research, and we just don't have it.
Yeah.
What we do need to advocate for in our individual therapy, in our individual medical appointments, and this is just speaking to everyone listening, obviously, is to make sure that you get a DEXA as soon as you can.
Yep.
There are a lot of pop-up DEXAs in wellness clinics now that can be as little as $50, $99, and you can get that done. I actually just popped into one today.
Oh,
As a
cool.
matter of
Yeah,
fact.
good.
Yeah. One in the clinic now that I work in is test driving one. So of course I got in as the test driver for it. And I had got a DEXA last year, but just in studying, I was studying for another post-grad thing, because that's what we do, right? We constantly are like studying to learn something new. And I was studying for a test. And when I realized what the guidelines were, I was like, that is such a massive disservice to women. It also speaks to, as a woman, if you're perimenopausal or menopausal, it's a good idea to go onto the NAMS site, North American Menopause Society, at menopause.org, and look for a menopause literate provider. Now, just because they're on the list does not mean they will necessarily be a menopause literate provider. But let me tell you, if they're not on the list, they are probably not menopause literate at all, and they might lead you down the wrong path, which means delaying estrogen, delaying testosterone, and other things that may actually be needed now. Progesterone is one of the first things that would be needed. But when you talk about bone density, of course, we're talking about, estrogen and testosterone. But it's those things that were completely neglected, even as little as 2 years ago. Utterly neglected because of operating on old evidence.
Yeah.
So everybody go get your DEXAs.
Yeah, I mean, absolutely. And the thing is, it's like, I can't say enough about our need for challenging our tissues at a level that is tolerable so they can produce an adaptive response, so that we can actually build muscle mass, so that our muscles are doing their metabolic magic stuff in the background, but we can't, and metabolizing blood sugar and doing all the things that muscle tissue does aside from opening doors. It's a metabolic machine, and it requires us to look at our body, understand it, not be afraid of it, all those things we talked about, and then say, you know what, this body is strong. It is designed to be strong despite its limitations and its unique needs and stuff in this realm. We have a path forward to help it mount an adaptive response and feel better and be more capable of handling the stresses of life, both mechanical and otherwise. And it's about longevity, really.
That's well said. Speaking of that, let's talk about action steps they can take. So we've talked about a little bit of advocacy, of doctor shopping when necessary, because you may not get the answers you want, of looking for literate docs in various fields, of getting the DEXA as early as you can, especially if you have a history of osteoporosis in your family, endometriosis, or hypermobility. Go and get that. But some of the things that we can do, let's talk about let's take a couple of minutes and just talk about other action items for them. I know that I know that we know how important breathing is for intra-abdominal pressure regulation and spinal stiffness and security and stability in hypermobile individuals who also have probably pelvic floor dysfunction too. So what are some of the ways that you have found that breathing is just like, an instrumental part, or maybe it's the way they start?
I think it's the way they start. It's a really good starting point. I often will focus on, the diaphragm, the lower half of the rib cage, as the epicenter of the movement of the body. This is where the diaphragm moves us. And so many hypermobile people are so rigid through their trunk, through their rib cage, and the ribs just can't move because they're being braced, as a kind of a compensation for extra wobble. So this attempt by the body to create some stability where there's not enough already, but it's a dysfunctional way to do it, and it leaves us without our big moving part with the breath, this rib cage, and it's the strength of our diaphragm, the strength of our intercostal muscles. And so when we don't have that movement and we just like move at the belly and then up here, we have all this neck, all chronic neck tension and neck pain. And That's almost universal among bendy people. And I do think it has to do with breathing mechanics. So I like to do resisted breathing with like stretchy band around the low ribs. And that's a nice tactile cue to help people become aware of that part of their body and start to invite some movement with the breath. And they have some resistance, which helps us feel stuff. Bendy people often need more resistance, whether it's the breathing exercise or hands-on tactile cue. They need more input to connect. So I like the resisted breathing for that a lot. And sometimes I'll have them continue to wear that during other types of exercises or during their whole yoga practice. They could just keep that on to keep anchoring their breath, not so low as long as we're in gravity. If we're relaxing on the ground, cool, belly super soft and floppy, right? But if we're in gravity, we kind of need the breath to be our buoyancy. It's part of our postural support. We have to learn how to get it in the middle of where we're used to putting it. Does that make sense?
Mm-hmm.
Yeah.
Mm-hmm.
That's awesome.
I love the breath imagery that you're talking about there, and use of the breath. You mentioned the stiffness, and I'm just like shaking my head. Yes, 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 yes. I see that all the time. The body will create stability wherever it can get it. And sometimes that's creating rigidity and fear of movement in the brain, or rigidity in the rib cage, like you mentioned, or in the mid-spine, or rigidity in the pelvic floor.
Yes.
Because the breath should move the pelvic floor, as we know, on an inhalation. So if everybody takes a deep inhale right now and you let the belly and the ribs expand, you should feel the pelvic floor stretch downward. But too many times it doesn't. That particular case that I was referring to earlier, when this particular individual came in, there was only about 6 millimeters of movement on ultrasound imaging when I looked at their breathing. Okay, 6 millimeters, if you get out your measurement tool, that is not much of anything. And we need a lot more movement than that, or the pelvic floor just becomes, I just think of it as being afraid, like tight, rigid, and afraid to move because of the lack of breathing there.
Yeah. So, I mean, it also highlights a bit of a counterintuitive point about hypermobile people, which is that their muscles are usually really tight. They're chronically contracted. So that's what we're talking about, the pelvic floor muscles, the muscles around the rib cage, and they're bracing like like you described them, and they can't move. Therefore, they cannot work well. So it doesn't really help to create more rigidity in the trunk with like certain, core stability exercises, all of that, if these parts can't move well. So it sort of feels weird to people to work on mobility in some ways, or to kind of improve the flexibility of certain parts before we, have our full team of trunk muscles that now they can start to manage intra-abdominal pressure better under some loads. But if they're rigid, they cannot do that job.
Yeah.
And those are the hypomobile parts: pelvic floor, rib cage, mid-spine, and shoulders. Actually, bendy people very often don't have full shoulder flexion range of motion. They got 160, 150, and then beyond that, they just throw their spine around. It's really wild, these patterns that you start to see in this population that are kind of surprising,
So you kind of just answered my next question, actually. You're that's very intuitive. I was going to ask, if someone with endometriosis suspects they may also have a hypermobility disorder, what are some key signs they should pursue further evaluation?
It's tricky because it's hard to find someone to evaluate it.
That's true. That's true. But that's why you're here and talking about it. And that's why you do your continuing education and things like that. So, if they see these particular signs that warrant further evaluation, what would some of those be? And they can overlap, because of course we can't just definitively say if you have A, B, C, D, and F, then it's going to be, A.
Well, the hypermobility assessments that are out there, that are commonly used to assess for generalized hypermobility, are really problematic. They're limited. So what I would say mostly is, when you Google those, like the Beighton scale, the 9-point scale, do not be deterred by a low score on that. You might score low on some of these joint assessments and still have symptomatic generalized hypermobility. See it all the time, because they're not comprehensive. But you might have been told at yoga or Pilates or dance, if you have a history of gymnastics, dance, yoga, you can almost guarantee that you're hypermobile. If that became your thing as a young person, it would not have become your thing. You wouldn't have excelled at those things if you didn't have some level of hypermobility, most likely. So that's a giveaway. When someone tells me they have a history of dance, yoga, ballet,
gymnastics.
Yeah. Then the dizziness is such a common one. The low blood pressure tendencies when you stand up and you get dizzy, or the brain fog, the fatigue, and pain, but myofascial pain, joint pain that just doesn't make sense, or you've had a lot of times there's the testing's all normal, the labs are normal, the x-rays are normal, and yet there's pain. Those would be some big flags to say, no, you could pursue this. Keep looking into it. I will say there's a terrible trifecta, which might actually pull in endometriosis a little bit. The terrible trifecta of hypermobility is bendy, itchy, and dizzy. There's the joint issues, the musculoskeletal hypermobility, and other related things. There's the dysautonomia or the dizziness tendency. And then there's the itchiness, which is that mast cell component, where I get splotchy, rashy, sensitive skin, GI issues, headaches, brain fog. Those are the things that are kind of implicated in the endometriosis relationship, I think.
Yeah, that is such a good way to look at it. So can you give everybody the trifecta again?
Yeah, the trifecta is my shorthand for it, which my colleague came up with: bendy, itchy, dizzy.
Bendy, itchy, and dizzy.
Yeah. And that is hypermobility. The itchy is mast cell activation syndrome, or let's say dysregulated mast cells. And then the dizzy is dysautonomia, heart rate and blood pressure issues. They so commonly show up together, and everyone has so they're different, show up differently. So like I have a lot of bendy and dizzy, and I don't have a ton of itchy in my pie.
Yeah.
Someone else might be primarily dizzy and itchy, but not so bendy, right? The bendy thing doesn't jump out at you, or any of those combinations. That's a really good.
That's a really great way to distill it. And it also helps you advocate moving forward with healthcare providers to trust yourself and not be deterred from getting the help you need.
Yeah, and one thing I'll also say, if you're pursuing diagnosis or treatment for all these things, do not buy the story from your doctor that says there's no reason to diagnose you because there's no treatment. That is a sign of a doctor that doesn't know anything about this. That is not true. There is so much medically that can help manage these conditions. And the problem is a lot of doctors don't know about it yet. They don't know that they have medications to help you manage your mast cells and your dysautonomia. And there's a low-hanging fruit that's not even pharmaceutical that can help. So I hear that all the time. My doctor said there's no reason to diagnose this because they don't have anything to do for it.
That's terrible.
It is.
Well, now you all know that that's a lie, and that's code for they don't know what they're talking about.
Yeah.
Yeah. And instead of helping you, they're pulling an ego.
Yeah.
And just saying there's nothing to be done. So that is hugely illuminating for those of you out there who are struggling with it. So I have kind of one, maybe two questions left. I have a bunch of questions. Maybe we'll have to do a part 2 at some point. When you're feeling overwhelmed with hypermobility and or endometriosis, and you have all these symptoms and a lack of medical support, obviously you can source the resources that we're about to share with you now that we will put in the show notes, links you can go to where you can find Dr. Hinsley. But what changes would you like to see based on that? Like when they're feeling overwhelmed, they're not getting the help we need. I know that you have laid in bed at night thinking about this.
Yeah.
What changes do you want to see in the medical and rehab communities to approach these overlapping conditions?
So much. I just wished I had 100 1,000 of myself who was just going around giving in-services at every primary care doctor's office, because it's primary care who's going to have to step up and deal with these things. The specialists just simply aren't going to do it. They don't want to. And, some of them do, of course, out there. It depends on where you're located. Where I am, it's bad. And primary care, poor things, they have, overly full plates. But that's where I'd like to see the change, at primary care, because this is a patient who goes there and primary care does their job of referring out, and they get nowhere. They wait months and months and months for these specialist visits, and they get gaslit. And now they're back. It's a little boomerang. And primary care is like, I don't know what to do with this patient. Right now they're getting stressed out because they've done what they think they're supposed to do. And it's stressful for them. So I'd love to see lots more education for primary care providers. I want them to be more confident and able to diagnose this. Go ahead and make the diagnosis. Oh my God, it's so important. For hypermobile EDS, it is literally a checklist. You check off the boxes, and if they check enough boxes, they have the thing. That's what it is. Go ahead and do it. No one else is going to do it. But that diagnosis, whatever it is, if it's HSD, like if they have symptomatic hypermobility, but they don't meet the criteria for EDS, diagnose them with hypermobility spectrum disorder, so that this person knows this is a thing. Now I can learn about it. Now I can stop chasing a diagnosis and stop wondering what's wrong with me. Now I have an answer and I can move forward with my life. It is so empowering and such an important step. If I could go do anything differently in my own life, I'd become a PA, because it's quicker, and I could sit in an office and I could diagnose things all day long. That's what I would do. I would just diagnose people with EDS, and then I would treat them.
Yeah, well, it does actually call for, and this would be more policy related, but it does call for a reevaluation of scopes of practice for people.
Yeah.
Because if you're charging a primary care physician who has no experience in evaluating any of these things, and you're charging them with diagnosing something that they aren't really qualified to do or trained to do, then it makes sense to evaluate scopes of practices for other healthcare providers who can actually diagnose this and treat it.
Yeah.
I think our system is a whole lot broken. I was going to say a little bit, but I'm just going to be honest and say it's a whole lot fractured. It's a whole lot broken. When PCP is supposed to diagnose everything from candida to a common cold to, ordering imaging. And we know, if we look at imaging studies, that quite often imaging that's ordered through PCP may not be appropriate at all. Whereas if they would come to a physical therapist who specialized in this, they could get their imaging, their diagnosis, their treatment, everything done. It would save time. It would save money for the person, for the system. So I think if we could revise, what we're able to actually do from a physical therapy standpoint, that would be a worthy task.
Yeah.
One thing I was going to ask is there a list where, for HSD and EDS, can you point the listeners toward a list that would allow them to kind of check some boxes to see if they need to go in that direction? And I think you were going to say something else, so I didn't want to interrupt you there.
Oh, that's okay. I just never thought of that. Like, that would solve the problem if PTs could provide a medical diagnosis. Wow.
For something that's very, very much in our wheelhouse. It is a musculoskeletal diagnosis, which we can diagnose in that wheelhouse of musculoskeletal health disorders. It just makes sense that if the Army is using PTs as a primary care point, and they have saved so much money, and their outcomes are much better, and their imaging ordering, the appropriateness of imaging ordering, and the amount of ordering for imaging is much lower. In other words, the care is much better. Then the civilian world should be following suit.
Yeah, totally agree. Yep. And then, we need more PTs too, who are well-versed in this, but they're the ones who have the background understanding for this to all make a lot of sense. And they see it all the time. They already are seeing it all the time. And, we don't learn about it in PT school. I didn't learn about it in PT school, and I have EDS, and I would have never in 100 million years thought I had EDS based on what I learned about it that one day at PT school. that's a problem.
Same thing goes for pretty much anything. If you talk to any healthcare provider, everything that you use in practice, you really didn't learn any of it. You learned basic science and modalities and stuff in your formal education program, but everything that you know that you practice every day, you took continuing education courses for, you did specialty training for. And I think that's true with, PCPs. I doubt they learned a single thing about hypermobility too. So we're kind of all in the same boat.
That's
I think
true.
we need to shift our thinking on policy and advocacy for that. Yeah. But to get back to that other question, is there a place where people can go? A, where can they find you? And B, is there a place they can go for those type of checklists so they can see, oh my gosh, I might have so many of those things. Let me take this information to my provider.
Totally. So the first rabbit hole you want to go down is the Ehlers-Danlos Society website, Ehlers-Danlos.com. So it's just search for the EDS Society, Ehlers-Danlos Syndrome Society. Tons of information. You can download the PDF, HEDS diagnostic checklist. It'll go through all the types of EDS, how they're diagnosed. You'll find all the information, and they have a provider directory. It's not to say everyone's on there who knows about these, but at least there's some there. You can start there and in your area search for somebody. Also, word of mouth. There are tons of people out there. You're not alone if you're thinking you have these conditions. So hopefully you can connect in your area. I know there's like a Facebook group in my area, things like that. Where you can find me is libbyhinsley.com. That's my website. So that's sort of go there and find everything. You can find me on social media. I'm most active on Instagram at Libby Hinsley PT. That's
all right.
about it.
Well, thank you. Thank you so much, Libby, for being on the podcast today. All of the resources that were mentioned are going to be shared in the show notes. So you can just go and click on those live links wherever you get your podcasts. And I think y'all would probably agree we might need to have Dr. Hinsley back for a part 2 at some point, right?
Well, and I want to have you on my podcast, which I didn't mention, which is all about hypermobility. So that's another good resource. It's called Zebra Talks Podcast.
Zebra Talks Podcast.
Okay. And I definitely want to have you on. So
thank you. I would love to chat about that. So you guys check out Zebra Talks Podcast also, and don't take no for an answer. Trust yourself. Trust your body. Your body is smart.
Yes. Thank you so much for having me.